and welcome to another Piper Pod. Today we're going to talk about blood gas analysis. I understand that blood gas analysis can be difficult or confronting for people, especially if they're starting out, don't get to play with it that often. And what I find is people often get confused by what they're looking at and overwhelmed by the amount of numbers. So my intent is to have something for all different types of people. So when you look at a simple blood gas analysis, the reason a lot of people go wrong initially is because they don't have a methodical approach. They essentially get the printout, they're confronted with all the numbers, and they try to remember all the random rules they've been taught before. They try to incorporate all the different cations or anions because they heard somewhere that they were important, and they get overwhelmed. Okay, they try to analyze too much. The purpose of today is to try to break down the blood gas analysis and give you 6 easy steps to follow with every analysis in order to get a good diagnosis, because that's what it comes down to. I mean, knowing all the science is fantastic, okay, but the bottom line is you need to be able to read a blood gas in order to hand over the patient's status. And that is our end goal once we finish this presentation. So looking at the 6 steps themselves, nice and easy right from the top, we have to consider, is the pH normal? And then we consider, is the CO2 normal? Is the bicarbonate normal? And then we need to know if the PO2 and or the SpO2 is normal as well. Okay, so that's all about getting our numbers, looking at them individually and seeing if they're normal. The next one is we need to see if it's the CO2 or the bicarbonate that matches the pH. And the last step we need to do is we need to check to see if there's signs of compensation. We do that by checking the alternative, carbon dioxide or bicarbonate, and seeing if their numbers go in the opposite direction to the pH. Now I understand that can be quite confusing. First couple of steps, pretty easy, then it gets a little bit harder, but I'm going to walk you through each step, and then we've got a bunch of examples at the end that we can work through together. So what I would recommend is take the time, pause the video, write down these 6 steps, because then at the end of this particular video you can practice the skill sets, get starting in being comfortable with blood gases. But before we get there, let's break down these steps. Let's decide why we have to do it and what is normal. Okay, so these are looking at steps 1 right through 4, looking at the normal value for the 4 measurements that we just talked about. So when we're looking at arterial blood gas, that's generally what the numbers are when they get thrown out. Okay, when you read them in all the textbooks, they generally talk about arterial blood gases. Now you'll learn soon that that may be a little bit confusing, or a little bit maybe give you the impression that arterial blood gases are the only way to go, but hopefully by the end of this you'll learn that there's an alternative to it. So when we're looking at the pH, it's nice and simple. A normal value within the human body is 7.35 to 7.45. That's it. Any lower, you're acidotic. Any higher, you're alkalotic. Nice and simple. A normal PO2, so this is essentially pressure of oxygen within the body, is anywhere between 80 to 100 millimeters of mercury. That is a normal PO2. A normal PCO2, so plasma-based carbon dioxide, is 35 to 45. Nice and easy to remember, because you may see that the numbers correlate with the actual pH. And the numbers themselves are the normal range. Don't think it travels the same way as the pH, because then you'll get confused, but at least the numbers correlate. Now when we're dealing with bicarbonates, anywhere between 22 and 28. Now sometimes 26 is written, so don't get too wrapped around the axles about 26 or 28, but essentially that's your normal range within an arterial blood gas, is 22 to 28. Now the problem is, in practice, most of the time arterial blood gases aren't taken. Okay, whilst in some organisations and some departments, they're quite easy to take. Okay, a lot of people are qualified in taking arterial blood gases, but it is quite painful for the patient, and it does have a higher statistics of complications as well. So a lot of emergency departments revert to using venous blood in order to do their blood gas. So they put a cannula in, they take a bit of blood whilst they're running the rest of the tests. They put a little bit off to the side in the ISTAT or the actual blood gas analysis, and it's done. Nice and quick, part of the routine. Now the differences, as you can see, for things like pH and bicarbonate and also lactate, just out of pure interest, they don't change that much, as in it's not clinically significant, the changes that you'll see between venous and arterial. Now the numbers that you see on the venous changes, these are essentially a mean score from a meta-analysis of a bunch of studies. Okay, so whilst they can vary, I figured for simplicity we'll just put a mean score of each and we'll go from there. So as you can see, the pH only alters 0.035. Okay, so it's not that big. It's essentially making 7.35, 7.38. Not too bad. And that's the same with the bicarbonate. You're going from 22 to 23.5. Okay, so not big clinical changes. The ones that you really have to look out for is your PO2. Now obviously, no big surprise there. PO2 is going to be significantly lower in the venous than it is in the arterial, okay, for obvious reasons. So just take that into account, and realistically, if you are doing a venous, look at the SpO2 for your guide towards any hypoxic state. Now using the SpO2 and the knowledge that it's probably going to be 40 millimeters of mercury lower in the PO2, you can get a pretty good understanding whether the person is hypoxic or not. Now with the CO2 in venous blood, there's a lot of theories for many years, all prior to 2001, which is why I'm a little bit surprised this is still a good argument, is that PCO2 would not be reliable at all in using venous blood. Now what they've found is if your PCO2 is above 45 in the venous, 100% guarantee that it's above 45 in the arterial. The only way you get a little bit unstuck is when it's in the mid to high range of normal. For arterial, you can get a slight change in the venous. Okay, now whilst it's a little bit larger than the other numbers, it still in studies doesn't prove to have a massive effect, and they actually haven't done the randomized control or the lit review to determine whether using venous blood gases will actually alter patient outcomes with their treatment. A lot of specialists believe that it will not at all, okay, but there isn't, at least not as far as I could find, any study that actually backs that up. So just keep that in mind. Most of the time, you guys definitely will be using venous blood gases, putting it in your ISTAT in order to read these numbers. So just keep in your mind that what you have learnt as normal has a slight difference. The main ones to look out for is your mid to high normal range of PCO2, just look at it carefully, and obviously your PO2 number. Alright, so that's step 1 through to 4. So that's our normal ranges. Now we need to distinguish what happens when things aren't normal. And that's what step 5 is all about. So when you look at step 5, what we want to do is, after looking at the pH, we first of all need to ascertain whether the pH is on the low side, meaning they've got acidosis or acidemia, or whether it's on the high side, meaning they're alkaline, okay, or alkalosis. So obviously, hopefully most of you know the pH scale. If it's low, then we need to look at the CO2 and the bicarbonates as well. Now I do apologise for this large P without an A on the actual thing. This is the best picture I could find, so try to bear with it. Okay, just realise that it's CO2 in the body and bicarbonates. So the way the scale works when we're dealing with acidosis or alkalosis is when you look at the CO2 component. When acidosis has happened from a respiratory point of view, then you have high CO2 levels. Okay, so your CO2 will be over that 45, okay, or over that 51 if you're using Venous, realistically. Okay, so high levels of CO2 causes respiratory acidosis, whereas low levels of CO2 causes alkalosis. Now that is the exact opposite when we're dealing with bicarbonates. Low levels of bicarbonates will cause metabolic acidosis, and high levels of bicarbonates will cause metabolic alkalosis. So a nice easy way to remember it, because we all love acronyms, is to think of the acronym ROME, R-O-M-E. And that will tell you that based on the pH, your respiratory values are opposite and your metabolic values are equal. Respiratory values coming from CO2, metabolic values coming from the bicarbonate, which is your HCO3. So as the pH lowers, the carbon dioxide rises or the bicarbonate lowers. Okay, so once you've seen which one follows it, that gives us an indication of whether it's more likely to be respiratory or more likely to be metabolic base. From there we move to step 6, which is looking at that compensation factor. Okay, now this is as much science as I need to go into for this particular one. Now, what you need to understand is the body likes to maintain homeostasis. So when CO2 comes into the body, it binds with water and you get the middle value. Okay, now that's carbonic acid. Okay, now carbonic acid is broken down into hydrogen and bicarbonates. Okay, now without going into too much detail, the body will produce more hydrogen or bicarbonate by allowing the excretion of the other in order to compensate for the abundance or lack of CO2. Okay, so that's what happens. Now when the body has too much free-flowing hydrogen ions, they become acidotic. When the body has too much free-flowing bicarbonate ions, the body becomes alkalotic. Now that is the balance of compensation, and the exact thing happens in reverse. If these particular mediators are produced metabolically, then CO2 will need to rise or fall in order to blow off the excess. Okay, so the thing that you need to take out of this slide is that the body will try to balance the pH utilizing the lungs and or the kidneys as its excretory organs. The body will always aim for homeostasis. So what you want to see is signs of compensation, or better yet, complete compensation being achieved until the body can regulate back to full normal values. Okay, so that's step 6, and that's the process that we go through from 1 all the way through to 6 in order to analyze the blood gas. Okay, so let's take a bit of time here, think about those rules. If you need to, pause it, get a pen and paper. We're going to go through a few examples. So you'll see a nice easy printout in front of you, and what I want you to do is just notate whether it would be acidotic or alkalotic or normal values that you see in front of you. And essentially this is what you do when you get a blood gas. Even though most of the time you get a blood gas printout, there will be a lot of additional numbers, and that's where a lot of the confusion comes from. So I want you to train to focus on these 5 values to do your 6 steps in order to give a good handover of the patient's status. You master that first, then you can move on to understanding the full science and really looking at the physiology behind blood gas analysis. Okay, so give you some time to look at these values. Okay, that's long enough. You need more, press pause. So hopefully the values that you got look like this. So obviously, when you break it down, looking at step 1, they're acidotic because it's less than 7.35. Step 2, again, acidotic because CO2 is greater than 45. Step 3, skip down, don't read it, remember step 3 was your bicarbonate, 24, therefore normal. Step 4, your PO2 and O2 sats are both low, so indicating hypoxemia. When you look at step 5, we have a CO2 acidotic value and a pH acidotic value, therefore the CO2 and the pH match. Now, do we have signs of compensation? No, we don't, because the bicarbonate is normal. Okay, now if the bicarbonate wasn't normal, then you can have signs of compensation. Okay, so that's how the whole process works. Now, when you are handing over, so you're giving this person over to somebody, then you can say it's an uncompensated respiratory acidosis with hypoxemia. If you don't know the causative agent, that's fine, but you know that. And if you hand over that, the person who you're handing over to knows that it's probably acute because there's no signs of compensation. It's respiratory acidosis because you've told them. But the biggest problem is that they need to fix first is they're actually hypoxic. Okay, so that's the clinical indicator of needing to fix it. Okay, so that's one example. Next one. Now what I'll do in the interest of saving time is I'll tell you guys to pause the video now, write the results down. Okay, hopefully this is what you got. So alkalotic greater than 7.45. CO2 is less than 35, therefore CO2 is alkalotic. The PO2 and the SpO2 are normal, so there's no signs of hypoxia. Sorry, I skipped a step. But the bicarbonate is 23, therefore within the normal range. Breaking that down, we have a respiratory problem because CO2 matches the pH. Okay, so therefore we automatically know that it's a respiratory alkalosis. Now, if the bicarbonate was acidotic values, meaning less than 22, then we would have signs of compensation. But because we don't, we'll diagnose this one as a uncompensated respiratory alkalosis. Now, this sort of pathology, if you will, or pathophysiology, is generally what you see when someone is hyperventilating. Not excessively, but still hyperventilating a little bit. Good news is they slow down their breathing, bring on more CO2, and the problem resolves itself. Okay, it's not a big emergency. Okay, so that one there, quite simple to look at. Changing the scale up a bit. So same thing again, pause the video, test yourself. Welcome back. Hopefully these are the values that you got. So, they're acidotic. Okay, it's relatively significant acidosis as well. Okay, so don't get confused by the shifting of these numbers. I did forget to mention that if you get down into the 6s, it is profoundly acidotic. Okay, so 7.18 is actually quite acidotic for this person. It is less than 7.35. Looking at step 2, CO2, 44. Okay, it's normal. It's on the higher end of normal, but it is still normal. The bicarbonate levels are sitting all the way down there at 16. So therefore less than 22, so that gives it an acidotic value. Okay, now, bit of a tidbit. Think of your bicarbonates the same way you do when you're doing cooking. Okay, bicarbonate is a natural absorber of acids. The more you have, the more likely you are to absorb acids. You have too many, you soak up all your acids. Therefore you're alkalotic. You don't have enough, you can't soak up acids, and you're acidotic. Okay, so that's sometimes a nice easy way to remember it. Step 4, normal, not hypoxic. Now in this particular case, we're looking at a bicarbonate value and the pH matching, meaning they're both acidotic. Okay, so therefore we're looking at a metabolic acidosis. Now CO2 is normal, which means they're uncompensated. Okay, so if the CO2 had an alkalotic value, meaning being under 35, then you'd have signs of compensation. In this case, you don't. It's actually quite high towards the opposite end. Okay, so this person needs help. Okay, needs your assistance pretty rapidly. Now, this sort of thing occurs usually with an acute, obviously, no signs of compensation, but metabolic disorder. Okay, so the early onset of DKA. Now, obviously, DKA can go on for quite a while, but this is what you'll see typically in your earlier stages of DKA. If you had a nice glucose reading there, it would make it a lot more clear, but we don't. So, we'll move on. Okay, example number 4. Pause the video, and here's your results. Now, looking at that value, 7.60, hopefully you all got that that's greater than 7.45, so they are indeed alkalotic. Okay, CO2, normal, bicarbonate, it's greater than 28, therefore they're alkalotic. Remember, lots of bicarbonate, soaking up all the acids, alkalotic. Okay, PO2, O2 sats, normal, no signs of hypoxia. Okay, we have a metabolic disorder because the bicarbonate matches the pH. And once again, we have no signs of compensation because the CO2 is normal. We would want that CO2 at the higher end, above 45, to be acidotic in order to compensate for this particular disorder. Now, this is what happens when you lose a lot of your stomach acids. So if someone is vomiting a lot, or if you're doing nasogastric drainage due to poison. Okay, now obviously poison makes it a little bit more difficult because a lot of poisons cause acidotic or basically blood gas problems. But essentially, if you lose gastric juices, this is the profile that you get. Okay, early stage, no signs of compensation. Now, the last one. Pause the video, do this last one, and hopefully here's your results. So, breaking it down, less than 7.35. They're acidotic. This time, they're less, the CO2 is less than 35, meaning that's alkalotic. Okay, step 3, much lower than 22, meaning the bicarbonate is acidotic. Their PO2 and SpO2 are low, meaning they have signs of hypoxemia. Now in this case, we need to look carefully. The pH and the bicarbonates match. Therefore, this is a metabolic disorder. When you look at the CO2, less than 35, therefore you are showing signs of compensation. So in this particular case, the CO2 is lowering as a means of trying to blow off your acids. So CO2 is low, you're not compounding the issue by adding more hydrogen ions to the mix by having lots of CO2 turning to carbonic acid. So what's happening is you're allowing your kidneys to slowly remove those acids and your body absorbing a less than normal value of carbonic acid. That's essentially how it works in a nutshell. So when we're doing a diagnosis for this one, we will call this one partially compensated metabolic acidosis with hypoxemia. Now the reason it's partially compensated is because the pH is still acidotic. Okay, it's only when the values, the CO2 and the bicarbonate values are in sync enough that it results in a normal pH that you could call that compensated metabolic acidosis. Now the reason for these ones, these sort of disorders are, there's lots. Okay, big ones, renal failure, profound diarrhea, essentially shedding of your bicarbonate layer within your body. I mentioned before poisons, later onset of DKA, but each one of those is at the chronic level, because of the actual oxygen levels, you have signs of shock occurring. Okay, so with each one of those, it is further end because you have signs of shock. So hypovolemic shock, septic shock, whatever it is. Okay, so that's just a quick overview. From here, practice. Okay, you need to practice. Get as many ABGs, VBGs as you can, and hone in on looking at those 5 values and doing the 6 steps and giving a good handover. Nobody is going to care if you just look at those 5 and give a handover that just says uncompensated, compensated, metabolic or respiratory, acidosis, whatever it is. That gives more information to the people that can fix it than you'd believe. What they will care about is you try to stumble around the actual ABG printout and try to give words like, oh, this is definitely, it's hyperchloremic, but I know that their lactate's normal. Oh, wait a minute, what's their AON gap? And don't even tell them that they're acidotic. So practice the 6th step, harness the skills, and when you're ready, get the science behind blood gases. Okay? Till next time, take care.